Hello, welcome everyone. We'll give everyone a minute to gather here in the Zoom room and we'll get set up and started. Thank you all so much for joining us today. Welcome to our 2025 community webinar series, Mastering Lewy Body Dementia Together. My name is Julia Wood and I'm the Director of Professional and Community Education here at the Lewy Body Dementia Association. And this year we've been exploring a huge range of topics to help you better understand Lewy body dementia and its symptoms, strengthen your ability to advocate for services and support, and pick up new tools and techniques to live optimally. All right, so our mission, of course, you guys are probably familiar with this, is to optimize the quality of life for those affected by Lewy body dementia. In order to do this, we accelerate awareness, advance research for early diagnosis and improved care, and provide comprehensive education and compassionate support. So a few technical items before we get started and before I bring in our presenter. You can launch closed captioning by selecting the show captions, button at the bottom of your Zoom toolbar at any time during the presentation. You'll notice there's also a resources icon on that same Zoom toolbar that has links that you might be interested in that relate to this presentation, and also some resources for download to accompany this content. And if you'd like, you can print out the webinar worksheet that is included in the resources to guide you through how to apply today's information to your situation. You are encouraged to submit your questions throughout the presentation using the Q&A icon. Following the presentation and panel discussion, we will address as many questions as we can from the audience Q&A pool. My colleague Rose Heitoff will be dropping links into the chat throughout the presentation, and these links will also be in your email box in about 1 week from today as part of our post-webinar thank you email. This presentation is being recorded, and an email will be sent to those who registered with the link to view that recording in about 1 week. When you leave the session today, please take a moment to complete a brief survey that asks about your feedback about today's presentation. We would greatly appreciate your insight there. All right, so in between, we do about one of these a month. You can keep learning. There's a lot of webinars that we've done in the past in 2023 and 2024, and even from this year that you can view on our LBDA YouTube channel, LBDA TV. And there's other content there as well to check out. And then also our Lewy Learning Center offers a lot of courses on a variety of topics that you can watch, rewatch, and share with your friends and family. Check out our newest course on the Lewy Learning Center, Redefining Intimacy with Tori Ricci. And then also something a lot of people don't know about is we have a whole channel on Mediflix where we have the film about Robin Williams, Spark and his battle, about Robin Williams and his battle with Lewy body dementia, and other videos that you can watch and share as well for free. And then we really advise, if you want to stay up to date with what's going on, current happenings and events around LBDA, please join our social media channels to hear about our webinars and programs, and even our community conference that's coming up this winter. All right, and with that, of course, you can visit our website at any time to find out all of your LBDA needs. So I'm going to stop sharing my screen now. We're going to find out a little bit about who's in the audience first, and your experience with Lewy body dementia. So Rose is going to launch a polling question here. So our question for you is, how long have you been either living with LBD? So this could be a person with Lewy, a care partner, maybe you're a friend, an advocate, a healthcare provider, a volunteer. And our ranges here, you'll notice, are 0 to 3 years, 4 to 8 years, 9 to 15, are more than 15 years. So we want to kind of get an idea of who's with us. This time I'm checking the numbers here. We got a lot of people coming in that kind of 0 to 3 year range. Excellent. So kind of more on the newer diagnosis. And I could definitely see why apathy a lot of times is one of those early symptoms that can really, really bother people. All right, so let me stop that and share the results with you. So you'll notice here about 60% of you, are in that 0 to 3 year range. We've got about almost 30%, 4 to 8 years, and then that 9 to 15 years, and more than 15 years, a little under 10% there, around 10%. All right, thank you so much. So we've got one more question here that we would like to know. And this really helps our presenter kind of know, and our panelists know how deep we want to go with this information. So how knowledgeable are you with today's webinar topic? So we're talking about apathy and all of the implications of that, the impacts on daily life. And so this might be a new topic to you. You might know a little bit about it. You might feel like you're very knowledgeable about today's topic. And some of you, we may have some experts in the audience, but I have a feeling, just like Dr. Fleischer last time, Dr. Wyman probably feels like this is such a complicated symptom that is anybody truly an expert? We, a lot of times, even as healthcare providers, don't feel very expert. All right, we'll give this a little bit longer here and give some of you a chance to respond, but it looks like it's slowing down. So I'll go ahead and end that and share the results with you. So you'll notice this time we've got 60% of you feel like you know a little bit about this topic. We've got almost 40%, it's pretty new to you. And then we've got about 9% feel like you're very knowledgeable. So thank you. That helps us kind of understand where we're coming in at. All right, so now let's meet our presenter. Dr. Kate Wyman is a clinical neuropsychologist and clinician investigator at LBDA's Research Center of Excellence at Struthers Parkinson Center in Golden Valley, Minnesota. She earned her doctorate in psychology from Pacific University and completed neuropsychology training at the University of Kansas School of Medicine, Wichita, and the University of Virginia Medical Center. She is board certified in clinical neuropsychology by the American Board of Professional Psychology. Thank you so much, Dr. Wyman, for joining us. Welcome.
Hi, thank you so much for having me. I'm really excited to talk about this topic because it is probably one of the most common questions that I get in clinic, and I find that apathy is kind of nebulous. It's really hard to make it tangible. So I will do my best. So thank you.
We'll do a great job. Take a moment to get your stuff going, and I will turn off my camera. But then if you want to ask if I can see it and everything before I leave, I can give you a heads up there, a thumbs up, I guess.
Okay, I think I'm ready to go.
Perfect.
Okay. Great. Well, thank you again. My name's Kate, and I am a clinical neuropsychologist. So one of the reasons I am really excited to present on this topic is because there are a lot of behavioral treatments for apathy. And so as a psychologist, I'm always excited to talk about some of those things. So these are our goals for today. I want to spend some time talking about a clear concept of what apathy is to the best of my ability, what it looks like for folks living with Lewy, and how it's different than something like depression. I also want to talk about some research-based strategies to treat some of these symptoms. It is extremely difficult to treat, but there are some things that can help. And then we're going to hear from the real experts who are going to share their lived experience of apathy in Lewy. So we'll dive in. So for some people, it can be difficult to motivate themselves, or even myself, to do something, for example, like exercise. So I have this depiction of a pole vaulter because I think it's a good metaphor for going to the gym. There sometimes is a hurdle or a barrier to go to the gym for many people, but we find that when we get to the gym and we're on the other side, we actually feel accomplished and feel better physically. But some days that bar to motivate that behavior to go to the gym is higher or lower than others. And we all have days when we kind of want to sit around, watch TV and do nothing. And on those kind of lethargic days, we might not be very social. Apathy is a little bit different. So apathy is, I would say, more severe, where people do kind of want to sit at home, watch TV and do nothing. But what really defines apathy is this reduced motivation and initiative and sometimes emotional responsiveness, but it interferes with day-to-day functioning. It's getting in the way of hobbies, social relationships, other things. We want to talk about what apathy looks like. It can look like withdrawal or maybe lack of enthusiasm, reduced decision making. And so a common symptom, you say, well, what would you like to do today? Or what do you want for dinner? I don't care. It is a very common response. And often apathy kind of impacts or bothers the people around you rather than the person living or experiencing apathy, because by nature or just by definition, they experience this reduced responsiveness to the environment. And some days this feels like this is the main symptom of Lewy. And sometimes the care partner or family member is doing everything they can to help motivate and prompt, and it seems like nothing works. So again, as we mentioned, apathy is a very common topic in our support groups because it can be so difficult to manage. It is an extremely common symptom of Lewy body. It involves motivation, emotional engagement, and withdrawal. So when we see behavior, it is kind of our nature to assume it's willful or intentional. But one of the things I really want to drive home today is that apathy in Lewy is related to a really complicated interaction between changes in neuroanatomy, the areas where we experience the Lewy pathology in the brain, and also chemicals in the brain, which change as Lewy body progresses. There are different forms of apathy. And I think, again, the one that we're probably most familiar with is the behavioral aspect of apathy. Reduced motivation to complete daily tasks, diminished desire to participate in activities, that indifference again, what do you want to do today? Nothing, or I don't care. Sometimes someone who has always been kind of a take charge kind of person may now kind of wait for other people to initiate or organize activities. And again, spending more time in front of the television than you did previously are some common symptoms. There are some emotional changes associated with apathy, which kind of include this loss of passion or reaction to news or situations that normally would evoke an emotion. Might be less concerned about things. Maybe an example would be, I had a family member say, well, he's just not motivated to pick up, kind of after himself. And you would think that, it would really bother him sitting there with a pile of papers, and really, it doesn't necessarily bother the person with apathy. And this is a symptom of the disease. There's also cognitive apathy. And this is really described as a loss of curiosity. So someone maybe who worked as a financial advisor really isn't interested in following the stock market or even really keeping up with bills, not interested in museums, less interested again in planning. And with cognitive apathy, it can take a lot longer to make choices when you have unlimited options. What do you want to watch on TV tonight? Or do you want to watch the news or a nature program? So we'll talk a lot about limiting options because the cognitive apathy, when kind of the menu is wide open, it just becomes harder to make decisions. Apathy, again, is extremely common in Lewy body, and it is often an early sign in the disease, an early symptom. And a recent study actually pooled the results of 49 studies focused on Lewy and apathy. And they found that one in two individuals living with Lewy have clinically significant symptoms of apathy. And that's true even for people who are functioning pretty well day to day. However, the studies really varied widely in terms of demographics, disease duration, and even the way that researchers measured symptoms of apathy. So there are some studies that report 100% of the participants in their sample met criteria for clinical symptoms of apathy. So some people would say, well, they just feel less motivated. Why should we care about apathy? But it should be identified and treated because it really is associated with decreased quality of life. People are less likely to participate in those really important rehab therapies that we know are beneficial for folks living with Lewy. They're less likely to exercise or engage in social activities. And we have a number of studies that show us those types of things slow down disease progression. Exercise, social activities are also important for mood and quality of life. So on a related note, when people have apathy, they have faster decline in functional abilities. And for some people, that can even look like earlier placement in long-term care. And apathy is really kind of stressful for caregivers and care partners. So the idea is, we have the person living with Lewy, the identified patient, but the whole system is really our patient. So this is why we need to identify and treat apathy. So is it apathy or is it something else? Apathy often co-occurs with other neuropsychiatric symptoms like depression, cognitive fluctuations. And so this kind of makes it harder to isolate and treat. Sometimes family members will say, well, my loved one seems depressed. They spend less time doing the things they enjoy. They don't really show very much emotion. Depression is a big issue. And there are a lot of commonalities between apathy and depression. So again, that reduced interest in activities, sleeping too much. But when we ask people, do you feel sad? Or do you feel hopeless? Oftentimes they'll say, no, not really. But if you ask them, do you feel kind of blah or, kind of not good, not bad? They'll say that's more like it. When someone has depression, they also can experience or tend to experience sadness, hopelessness, self-criticism. So depression and apathy are related concepts, but they are different. And it's important to figure out if it's apathy or depression because the way we treat these symptoms are different. There are other Lewy symptoms that can also look like apathy. So people can just not be, as quick to get up and do things as they used to due to Parkinsonism. Sometimes with cognitive fluctuations, if we're having a really bad day, we may be more inclined to kind of sit, and that can look like apathy or feeling or someone is not motivated, fatigue, and then of course discomfort from rigidity or constipation. None of us really like to do things when we're not feeling well. So apathy can coexist with all of these symptoms and complicates treatment, but sometimes we want to kind of tease apart some of these other symptoms of Lewy because the way we treat these are a little bit different as well. Now that we've defined apathy, I want to shift gears a little bit and describe some of the changes that are associated with Lewy pathology that really contribute to these symptoms of apathy. So apathy is one of those key neuropsychiatric symptoms. It's strongly linked to widespread dysfunction in the regions of the brain that are involved with motivation, reward, emotions. It's a really biologically based symptom. So it's not a matter of someone is being lazy or, stubborn or those kinds of things. There are actual changes in the brain that are causing these symptoms. So this slide is a little intimidating, but really the goal is just to demonstrate how many distinct regions of the brain are involved in that goal-directed behavior. The neurobiology of motivation is extremely complicated, and it makes apathy really difficult to manage because not only do we have multiple areas of the brain involved in multiple circuits, we also have some changes in the chemicals in the brain. Functional neuroimaging studies show us that when there's reduced activation in these areas that are highlighted here, we look at the metabolism or the way that the brain is using glucose. And when we have what we call hypometabolism or reduced use of that glucose in these regions, the severity of the what we call hypometabolism is associated with worse symptoms of apathy. So again, very biologically based. I just want to highlight a couple of specific areas. And again, there's no quiz at the end of this. And for some people, this is too detailed. But essentially, I want to just highlight the part here that's in purple. That's the prefrontal cortex. And it's very important for planning and then kind of reinforcement of that rewarding behavior. When we do something and we kind of feel good after we do something, we're more likely to engage in that behavior. The prefrontal cortex does not work as efficiently as it did prior to Lewy. The blue part here is called the anterior cingulate cortex, and it is also important for kind of that motivation and initiation of behavior. Then we also have these deep brain structures. And you can't really see them in this slide for reference, and any of my colleagues or anybody on the call who knows a lot about neuroanatomy might be cringing at this slide. But essentially, it's just showing there are also deep brain structures. And those deep brain structures have a lot of connections with the rest of the brain. So the basal ganglia is central to reward and motivation. Dysfunction in the basal ganglia disrupts our kind of goal-directed behavior. Disruption in the basal ganglia is also associated with symptoms of Parkinsonism. We also can see some changes in the limbic system, or something we call the amygdala. And this is really the center of the brain that helps with emotional reactivity, recognizing emotions in other people. So again, these connections, the neurons are not communicating as efficiently as they once did, and that can explain some of the symptoms of apathy. So neurotransmitters are these chemical messengers that really allow our brain cells to communicate with one another. So we see a pretty significant reduction in neurotransmitters in folks with Lewy. And the reduction in neurotransmitters, it's really associated with a wide variety of symptoms. It could be motor symptoms, autonomic symptoms, but what I want to talk about here is dopamine. And when we think about dopamine and having rewards after engaging in a behavior, this is the key neurotransmitter, and it's highly associated with apathy. Dopamine is also important for cognition, executive functioning, planning. Cholinergic deficits. So this is another chemical in the brain. It's linked to kind of, again, that difficulty with motivation, but cholinergic deficits are also associated with cognitive fluctuations. So sometimes we can see more severe apathy in people who have more severe cognitive fluctuations. And then the final kind of neurotransmitters I want to mention are called serotonin and noradrenaline, and they have a lot to do with depression and sleep. So you can see that there is a very complicated relationship between the chemicals in the brain and these symptoms. This is another really busy slide, but I want you to focus here just on the picture of the brain rather than all that written content. This picture is really depicting all of the different regions of the brain that are involved in the dopamine pathways. So again, dopamine is that critical neurotransmitter, and we see all these widespread connections. When dopamine is reduced, which it often is in folks with Lewy, it is going to have widespread implication and just make it more difficult to find that magic bullet or that magic treatment to improve apathy. So now that we've reviewed some of those kind of biologic mechanisms, I want to kind of get to the heart of the discussion today. So apathy is common. It's associated with poor clinical outcomes. But what do we do about it? So I want to return to the idea of this pole vaulter. So we've learned that there are several reasons that the bar or the hurdle is higher for people living with Lewy. The tasks are not necessarily insurmountable, but we do need strategies to kind of give that extra boost. Just like people feel better when they get over the hurdle and go to the gym, people with apathy feel better when they get to the activity. So the hurdle from apathy to action has changed. So we need to kind of partner together to be helpful. I will say, and as a psychologist especially, I hear this a lot. I recognize relationships are hard in general, even without Lewy. So when there are symptoms of apathy that are impacting kind of care partners, family systems, it just can be really, really challenging. And it's important, again, that to know that this is a symptom. It is okay to be mad at the disease, but try really hard not to be mad at the person. Again, when there's behavior involved, it's hard not to think that it's intentional. But I'm hoping that this webinar will be helpful in providing some understanding. So previously enjoyed tasks might be too difficult or frustrating. So it might look like the person is maybe quick to give up on a task, but maybe it's just not fun because it's too challenging. So breaking down tasks into smaller achievable tasks can be really helpful. So for example, some people enjoy jigsaw puzzles. I'm in Minnesota. It's a very common winter activity. A 1,000-piece jigsaw puzzle might be too overwhelming. So we might consider a 500-piece puzzle, one that has a lot of different colors or aspects, or even just saying, let's work together and sort by color instead of just setting the puzzle in front of someone. Maybe even encouraging, to try a new hobby. Would you be willing to give it a try? That can be helpful. Sometimes people find out, maybe a little later in life that they really enjoy watercolor, for painting, for example. But it's also important to recognize one of the hurdles with Lewy is that fatigue, motor symptoms, cognitive fluctuations might interfere. So pacing activities and, kind of preparing to just maybe try again a little bit later are important strategies, especially over time. Another big hurdle in Lewy is what we call executive dysfunction. And I think about that like the executive of a company. It's kind of the planning, organizing, multitasking. That's one of the big cognitive changes that is very common for folks living with Lewy. So when you're feeling a little bit disorganized, setting a routine, scheduling activities in advance can be really helpful. Avoiding open-ended questions. Again, when the menu is too big, it's kind of like, I don't care. I don't even want to start to think about that. So instead of, what do you want to do today? That opens the door for someone to say nothing. And so having too many options can be overwhelming. So, we should go do something today. Would you like to go to the park or should we, walk to the coffee shop? Or even a more active prompt, which hat do you want to wear during our walk today? When we think about the term motivation, we think about, enthusiasm or drive. We think about it as a positive attribute. And if someone loses motivation, we can fall into the trap of maybe labeling the individual or even ourselves as lazy. So I want to introduce this concept of goal-directed behavior. So these concepts are related, but they differ in really important ways. So here's an example. John is not motivated to exercise. Or even John is lazier than he used to be because he won't exercise. Versus John used to go to the gym 3 days out of the week. Now he goes maybe once per month. Loss of motivation is vague. And it also is maybe, we're putting on a value, or this is an attribute of who you are. You're being lazy, you're being stubborn. When we talk about goal-directed behavior, this is really something that's specific, and it's talking about the frequency of a behavior. So John used to go to the gym 3 days per week, so we've got a reduced frequency of the behavior. It's observable, it's measurable, and it's objective. So oftentimes marital therapists, for example, will say, instead of saying, you are rude, what you said to me came across as rude. So really trying as hard as we can not to talk about the person, but really talking about the behavior, because that's when we can identify the behavior and start to address it. So this is a psychological concept that some of you may be familiar with. It's called behavioral activation. And it's a really effective evidence-based technique that's focused on increasing engagement in that meaningful goal-directed behavior. So this takes place through activity scheduling and also reinforcing these positive experiences. When we feel unmotivated, often the first thing that goes out the window are kind of the optional or the fun activities that don't seem as fun anymore. But we still have to go to the bank. We have to go to the doctor, those kinds of things. So life becomes a series of chores. The goal of behavioral activation is to increase your access to these rewarding and fun experiences. So in other words, the prescription is to have fun, even if it doesn't sound like it's going to be fun. And we'll talk about that a little bit more. But again, this behavioral activation can also be a really effective treatment for depression. When people start to self-isolate, again, they're not allowing themselves, they're kind of robbing themselves of an opportunity for joy, is really kind of how we look at it. So the first thing you want to do is identify person-centered interests. What kind of things have they traditionally enjoyed? Just because maybe going to a soccer or football event might sound interesting to me, let's go out and try something. It may not be interesting to my loved one or the person living with Lewy. So what is going to be interesting for them? Again, identifying these patterns, these changes in behavior. How frequently are these behaviors occurring in terms of how frequently are you meeting for coffee or going for a walk? When we can identify the behavior, then we can plan and intervene. We want to kind of gradually increase activity. We don't want this to be an all or nothing. So even though I say the prescription is fun, put this on the calendar like it's a meeting that you have to go to. We're going bowling, or we're going out to lunch. Don't do that 7 days a week right out the gate, right? We want to ease into this. We also want to balance activity and overstimulation. So again, offering limited choices. The person with apathy, still has agency and wants to be able to have some say and some control. But again, when the options are too wide, that becomes frustrating. We want to schedule activities when the person is most alert, and we want to adjust the tasks. for both cognitive and physical limitations. So scheduling activities when someone is the most alert. So I conduct neuropsychological evaluations. My appointments don't start before 12 o'clock because many people, particularly people with Parkinsonism, kind of say I have some trouble getting going in the morning, or sometimes I'm fatigued and it takes me a while to wake up. So again, thinking about what is the best window of the day. Some people say I need a nap in the afternoon, or I get more confused in the afternoon. So kind of keep that in mind. Focusing on that routine and predictability and stick with the plan. Sometimes you need to do some simplified instructions or visual supports. But for those of you who are kind of early in your journey, thinking about developing those good habits and good routines now will serve you well in the long run. And that's true for all of us, really. So this is the most important step in behavioral activation, I guess, besides doing the activity. Reinforcement and feedback. Positive reinforcement, verbal praise, emotional support, that is really going to strengthen that engagement. Reflecting, how did it feel to complete that task? Or I noticed this, when we engaged in this task. So the person with apathy might not have that emotional recognition or awareness to kind of explain how they felt during or after the task. But you, as a care partner, can also kind of observe that. And I'll give you an example. Here at our Parkinson Center, we had an educational event a couple weeks ago. And during part of this educational event, we had a breakout session where family and care partners were with our social work team, and people living with Lewy went with our physical therapist and our music therapist. And they did power moves and did some drumming. And I don't know, there's just kind of the joy. It's hard to explain, but just kind of the energy and the joy, as people were kind of transitioning back to the larger group, was really, really evident. And so, some people who were in the group maybe didn't necessarily appreciate it or recognize it, but it was apparent. And I think something that was really, really cool. So again, relationships are challenging, and I'm not saying I do any of these things right or do any of these things well, but care partners will often say that they feel bad. They're always prompting or trying to engage their loved one, or they're, they're kind of weary. So some of the phrases, it's time to, we have to, or even you have to. Asking the person with Lewy to come alongside rather than giving instruction can be really, really powerful. Will you help me fold these towels? Encouragement and positive feedback are also critical. I like how you did that. I really appreciate you. Your loved one with apathy might seem as if they don't care or don't notice when you kind of have that reinforcement, but they notice your words, your tone, and that reinforcement. Trust me, as a psychologist, that reinforcement goes a really long way. And so again, apathy is extremely difficult, but there are some communication strategies that may be more successful than others. So here's an example, a real life example, actually. Instead of saying, we need to get ready, are you coming or not? Or do you want to come with me? Set the expectation. What are we doing? Where? When? We're going to go meet Bob and Jane for coffee downstairs in 20 minutes. I'm going to help you let's get ready together. Offering a limited choice. Do you want to wear this blue shirt or this red one? And then providing praise or reinforcement. I'm really glad we had coffee together. I think Bob and Jane were excited to see you. And you can ask someone to reflect, how are you feeling? Or again, you can tell them what you noticed, kind of like with the power moves and the music exercise. Um, Gosh, you're really smiling a lot, or it seemed like you enjoyed that. So some days are going to be more successful than others. You're going to hear from a panel of experts with lived experience who, may or may not tell me if I'm on the mark or off the mark. So trying these strategies, trying what fits for you is really, really important. But again, partnering together is an effective strategy. Okay, it's time to brush our teeth. I'll get the water running. I'll put the toothpaste on the brushes, and let's do this together. And just making it seem just as natural and normal as possible is much more efficient than you need to brush your teeth. Nobody really likes to be kind of told what to do, but it's just really hard because I find care partners are really doing the best they can to help their loved ones stay engaged and stay healthy. So it's just a really, really tricky thing to treat. So another important concept here is that you are not alone. Again, apathy is so prevalent. So reaching out to support groups or other people who also are familiar with Lewy can be really important, but also your treatment team. You're not alone, and there are things the treatment team can help with. So unfortunately, we have not identified medications that adequately manage these symptoms. Clinical depression, we can treat that with counseling and antidepressants. Some of those medications for depression can play a small part in treating apathy, but they are not as effective. So really, and in Lewy especially, non-pharmacologic treatment is always preferred. And again, the behavioral activation is more effective than medication in helping people stay physically, cognitively, emotionally engaged. As we talked about, there's so many different regions of the brain and different neurotransmitters that we just can't target this with one medication or one technique. So enhanced activities, routines, and support are really, really important, especially from friends, family, but also community supports and your treatment team. In terms of medications, some of the medications, acetylcholinesterase inhibitors, that's a long word many of you might be familiar with, but medications like donepezil or rivastigmine, those medications, for a more simplistic way to describe it, kind of increase the amount of this neurotransmitter in the brain. So they help with that cholinergic deficit. They can be effective in treating some symptoms of apathy in folks with Lewy. They also work, we also use them to help with cognitive fluctuations and sometimes hallucinations. We know all of those symptoms can co-occur, and the severity can be similar. So that kind of is one of the first lines of treatment. There's no evidence to really support the use of things like Adderall or Ritalin, some of these stimulant medications in increasing motivation or behavior. So partnering with your medical doctor is really important. If you think someone has apathy, talk to your medical team and see if they have any thoughts or ideas. Occupational therapists, Julia, and we got Julia on the call here, who will also participate in the panel. Occupational therapists are so talented, and they can find ways to adapt previously enjoyed hobbies, and kind of meet those changing cognitive and physical abilities. So here at our center, 2 or 3 times a year, we host events like adaptive golf. Many of our patients have trouble golfing because of either balance problems, sometimes stamina. They get fatigued really easily, or it just takes longer to get from point A to point B. So there are a number of adaptive strategies. I feel like in Minnesota, I might be the only person that I know who doesn't golf. So this has been really, really important for our patient population. I think later this week, they're doing adaptive pickleball, for example. So sometimes people give up their hobbies because they're too challenging. And, it may look different, but there are still ways to stay meaningfully engaged. Our physical therapists can help with personalized exercise routines that are safe. And of course, psychologists and counselors can promote that behavioral activation, getting a plan together, and assisting with maybe strategies and stress reduction techniques. Other members of the team, people with apathy are often more engaged when they arrive at the event or they're at the meeting than they are when they're at home. So support groups, and sometimes that looks like rock steady boxing or a coffee group, where you're not really talking about the symptoms, but you're with people who get it. That can be helpful. Day programs that offer structure and support. But really, this last point, I think, is also an important one. A personal care attendant may be helpful in encouraging some of those activities of daily living, sometimes go for a walk or do some of those things, but also some of those activities that can be impacted by apathy, like bathing or grooming. Having some support with that will allow you to spend more time together working on more rewarding activities. So really the idea is that having a support system that is in keeping your loved one engaged is beneficial for everyone. So looking to the future, we talked a little bit about this is really challenging to treat. We don't have great options, but we are always looking for ways to improve the quality of life for people living with Lewy and their loved ones. And so I'd like to briefly share 2 recent studies that may help us find new ways to manage apathy. So this is hot off the press. It was the results of this study were just presented about 2 weeks ago at the Alzheimer's Association International Conference in Toronto. So hot off the press, the Pointer study. What this was is they looked at individuals in the community who are at risk for cognitive decline. So older adults, and really it's a packaged lifestyle intervention. And you can see some of the key components here. Physical exercise, 30 to 35 minutes per week. 4 times a week, 30 to 5, not just 30 minutes a week, 4 times a week. It's okay if you start once a week, but we want to ramp up. Cognitive exercise, puzzles, games. Often people will ask, well, should I do crossword puzzles? Should I do Sudoku? And really, it needs to be something that you enjoy. And it needs to be something that's sufficiently challenging, but not to the point that it's too frustrating. So cognitive activity, the mind diet, and we can provide some links or some information about the mind diet. But the Mayo Clinic has a lot of really good information about that. And so this is more of a Mediterranean diet. We know this can help promote brain health in the long term. And then the program also involved some monitoring of health vitals. So you might say, well, we know these things are important for brain health. What is so exciting about this study? There was a unique aspect. In the study, some individuals, had their program, Other people were placed in a group where they had greater support, and greater intensity and accountability than the self-guided group. And not surprisingly, both interventions, improved quality of life and cognition, but the benefits were even greater for the people who were in that structured intervention group. So again, we're reinforcing the idea that there are health and brain health habits, healthy habits that we can employ. But this program, I was really excited. This program may offer a lot of promise in terms of keeping folks who experience apathy engaged and healthy. So stay tuned for more with the Pointer study. And then the second study I wanted to talk about, there's new medications that are under investigation for treating symptoms of Lewy. Recently, the results of the phase 2 clinical trial, the SHIMMER study, suggests that this medication may have a positive impact on neuropsychiatric symptoms of Lewy. So we're going to continue to research this medication, but you can find some information about the SHIMMER study on the Lewy body, the LBDA website. So there are some things in the works again, but those behavioral changes, which are really challenging, are going to be the most important and impactful at this stage. So I've thrown a lot at you in a short amount of time. So I will just highlight some of the things that I think are important. I would say apathy is diminished goal-directed behavior. I know I used the term motivation quite a bit, but really goal-directed behavior makes it more objective and less of a personal attribute. This is a biologically based symptom of Lewy. It's okay to be angry at the disease. It's fair to be angry at the disease. But again, relationships are hard, but trying not to be angry either, with the person who maybe isn't as engaged, or not being angry with your care partner who is maybe trying to encourage you. This again is really, really challenging. Apathy again interferes with things. Let's partner together rather than kind of telling you some of the things you should do, and then discussing apathy with your care team so we can get a good plan together. Make time for fun. Put that activity on the calendar. Follow through like it's an appointment or a meeting. People often feel better when they do the activity. Creating specific goals. I am only going to the gym once a month. Maybe I'll try to go for a walk for 15 minutes 3 times a week or 2 times a week. Start small and celebrate those small successes. Avoid open-ended questions and offer kind of more of a limited range. It's a lot easier to choose from what you want from a menu that has 5 or 6 things versus some of these places with multiple pages. Offer encouragement and positive feedback, and then recognize that the pace or the complexity of these tasks is going to change over time. So be prepared to adapt, be prepared to try again later. Those are kind of some of the things that I wanted to share with you today. For those of you who are living in the US, please don't forget the Lewy line. That's support services in a national network of volunteers who can help with a number of things, helping find some of those structured programs, supportive listening. So if you are living in the US, this is a wonderful resource. So with that, I thank you for your time and attention. And again, we're fortunate to have a panel of real experts on this topic. So I will turn this back over to Julia.
Right. Thank you so much, Kate. That was such a wonderful, wonderful presentation. You guys, please use your reactions at the bottom of the screen to show Dr. Wyman some love and also show some love to our panelists coming in. Thank you all so much. So, I'm going to start off by introducing our panelists. So, today with us, we have Janelle Greenberg, and she is a board member of the Lewy Body Dementia Association and a volunteer with University of California, San Diego's Alzheimer's Disease Research Center. She facilitates support groups for people with dementia and their caregivers, drawing on her personal experience caring for her husband with LBD. A retired social worker and family law attorney, Janelle is also a dedicated yoga practitioner and teacher. Thanks for joining us, Janelle. All right. And then next up, we've got Todd Doty. And Todd is a 60-year-old retired IT executive who was diagnosed with LBD in late 2021. He's a father of three amazing kids and a former golf addict who now loves woodworking. He's a proud leader of LBDA support group for men living with Lewy. And then last but certainly not least, you guys, Maggie Isaac has held a diverse range of roles over the years, from a quality control specialist to a high school biology teacher. She then managed inventory and supply chain operations, worked in a blood bank, and most recently served as a hospital reservationist. At 52, she was diagnosed with Lewy body dementia and transitioned to disability. She's supported by her husband and sister and cherishes her relationships with her stepchildren, grandchildren, cousins, and nieces. All right, you guys, thank you so much for taking the time to join me today and talk about this topic. It's so important. Thank you all. Okay, so we'll get started. I've got some questions here that we discussed ahead of time, so no surprises. And our panel knows too that if for any reason they want to refuse a question, they're welcome to. And I think that, a big point of confusion that I know, Todd, I've heard you talk about, and a lot of people talk about is, how does apathy really show up for you or your loved one? And how can you tell the difference between apathy and depression or fatigue? So do you have any insights of how somebody can tell the difference, or maybe how someone could communicate with their family at home? Do you want to start, Todd?
Sure. For me, it was kind of confusing because originally I was diagnosed with severe depression. And for those that know me, I'm one of the most upbeat, chipper kind of people that you're going to engage with. And I was shocked when I got to the point where I just lost interest in the things that I love doing. And even just simple things like instead of, wanting to get up in the morning and bathe, get ready, make breakfast, it just starts to slowly go away. I think at least to me, one of the hallmark signs for me was that it wasn't associated with any kind of sadness. It just was this complete lack of desire to do the things that I'd grown accustomed to, the things that I love doing. I love to cook, and I just didn't care anymore. People even ask, what do you want for dinner tonight? And it would be takeaway food. And like, I don't care, whatever you guys are hungry for. And they started to notice it's like, Dad, that's not you.
Yeah, absolutely. And that it sounds like even from your perspective, sometimes it was confusing to tell what was what and understand that.
Very
That's
much so.
yeah, very challenging. And then Janelle, as a care partner, what did you notice, or how did that show up for your husband?
Well, I think my husband was diagnosed in 2015. He passed in December of 2020, but there had been symptoms for years before. But he was a very active, engaged person. I mean, this man would read a technical manual standing in the line at the grocery store because he just was always seeking input. And I just noticed it was very slow progressing, but really by the end, I'm talking just in the last few months, fortunately, because it was slow progressing, um, so many things. I mean, he was a fastidious dresser and would always, wash and clean and all of that, and just lost complete interest in keeping up with his hygiene, which was completely unheard of. Uh, Again, not completing things, just he would ask for something to do, something like open the mail, fold the towels. I mean, whatever he just do a little bit and kind of walk off and lose interest. And I think the timing in my situation was so influenced by the fact that we were 2020, which was his last year, was the middle of COVID. So we were disengaged anyway. There was a lot that was not happening that would have normally been happening. So at the time, I didn't maybe make as much of it as I could have, or now looking at it in retrospect, there was a lot more withdrawal that was not necessarily incident to just there having been the fact that we couldn't go out and socialize like we might have previously. But so I did notice those things. I mean, just an insidious decline in engagement with the world, so contrary to the way that he had been for 30 something years, that I had known him.
Absolutely. I think that's a really common experience for people. And it sounds like hindsight was a little 2020, kind of in retrospect, it was more visible. Yeah. And then Maggie, how about for you? Did it feel more like depression, fatigue, or kind of how did your apathy show up?
Well, mine began to feel like just a no, I don't want to do this particular thing. I don't feel like it, which is different than fatigue. It's not that I didn't feel tired. I hurt. I don't, it's not the I'm tired. I just, just give me 10 or 15 more minutes more sleep and I'll be up. I just need to, or I'll just need to get it moving. One of those kind of mornings, I'll just say that I need to just give it some time to get moving. This is more like you don't want to say it out loud, but it's like you feel like a petulant 3-year-old by just saying no, I don't want to. And you sit down with your arms crossed and you just don't feel like it. And you're not doing it, but I'm grown and therefore I'm not. So, that's the way that it showed up for me.
Absolutely. And did your family find that kind of confusing? Because it sounds like that was really out of character for you.
It was a change. Yeah, it was a change. It's like, well, you don't normally act this way. You don't normally, you said you would, so you need to get it moving.
Yeah. And let's start with you, Maggie, there then. So, what strategies or changes or adaptations have helped you kind of overcome that hurdle of feeling that no, I don't want to do it?
It's more of a planning thing. You have to put it on your calendar. It comes up, it beeps, and your phone beeps, my watch beeps, and it's time you got to do it. And people are, if you have it so that people are depending on you, if you have a function at the event, so that that you have to do this to fulfill that thing at this event, whether it be a volunteer, just to do something at there.
A little more accountability. Yeah.
Hand out this thing, you got to do something.
Gotcha. And you said something in your intro too that I found motivated a lot of my patients, and that was grandchildren, engagement with children, grandchildren, family. Nobody wants to let down their grandchild, A lot of times spouse might be different.
This is true. And so, well, that's what I had, that was for the other question that you had. But yeah, grandkids and family. But most of all, for this question, I just had for planning. You gotta just plan the event.
Nice. And then Janelle, I'd like to pull in a comment or a question actually in the Q&A that I think relates to something that you said. And I was wondering if you and your husband ever found a workaround. Someone talked about, their partner losing interest in their hygiene, and you kind of talked about that in their appearance. And they said, he'll go out looking like a, really disheveled, and that's not normal. Was there it was COVID, so maybe you didn't have to find a workaround. I think we were all at home looking really disheveled, probably. Did you ever find a workaround for that or anything that helped with that?
Well, I think just being realistic in expectations was helpful. I mean, I remember in particular, we had an incident where this was really in the last few months. I mean, we already had hospice on board. And so one of their nurses came out to try to, help him take a shower. And let's just say it did not go well at all. And up until that time, I really was kind of fighting. I mean, I was just resisting and thought, okay, I'm not going to do this. I'm going to use my resources and let the nurse that does this all. This is what they do, and it just didn't work. He wasn't going to have it. And contrary to the way he'd been all those years, it just really didn't matter. It was different. And I think I had to wrap my head around that a little bit. And I think just generally, whether it's hygiene or any number of other possible issues, is to just choose your battles, figure out what is most important and what's not so important. And showering or washing as frequently as maybe he'd done all his life, if it was clearly not as important to him as it had used to have been. And I just had to come kind of to accept that. I mean, within reason, short of, health and basically taking care of him as best I could. At some point you have to say, it's fine. Let's just hang out, and if you don't get it done, you won't get it done and the world will not end. And I think that idea of choosing your battles is the caregiver. You want to try to fix everything. You want to make it like it used to be. And you can't always do that because it's just an insidious decline that your loved one experiences. And so it plays out different ways, but try to be as realistic as you can, as you live with the journey.
That's really good advice, to give yourself grace and give your partner grace too. Yeah, pick your battles. Good advice. How about for you, Todd? Like, what kind of workarounds? Because I know you're really involved in a lot of things. What has really worked for you?
Kind of like what Maggie said, and what our wonderful, amazing presenter talked about is scheduling things. Being an IT geek, I have a lot of computers, and I still stay very active with that to keep the juices flowing. But I schedule things on my phone, and it gets down to kind of nitty gritty. It's like 9:30 at night, brush your teeth, Todd. And I put a little picture of a toothbrush and toothpaste tube because, Apple lets us do that. And then 15 minutes later, another one pops up. Hey, Edie, want to keep your teeth? Brush them. And it's somewhat self-deprecating, but it's a constant nudge in the right direction for me. And I do the same thing with, daily activities. I, set up, wood shop, and I started making cutting boards and other things just to keep active. But the apathy will kick in. And I think the term that's been said over and over is insidious. And I use that all the time in our support groups and in discussing what it's like, especially, from our side. We know how bad it is, and we know how difficult it is to overcome. But finding, anything to keep yourself engaged is just critically important. It doesn't matter what it is. If it's, walking in the backyard and, taking a pair of cutters and just trimming, 2 leaves off a bush, that's fine. You're getting out, you're moving, you're doing something. Anything to keep yourself engaged and active, I think, is just critical to help fight this, horrible part of the condition.
Absolutely. And a question, this is one that I am throwing a little bit of a side bar at you, but what I found and what the research suggests in, especially with Parkinson's with goal-oriented behavior, is that once we kind of crack that door open, like you're saying, like once you find that thing and you get involved, then it seems like people find more things to get involved with. It's like that initiative is kind of boosted because like Dr. Wyman was talking about, you get that reward, of interacting with people or the thing you made or whatever it is. And so we find that if you can just kind of get over that barrier, I talk all the time about my gentleman that just wanted to make his own drink. And it
Mhm.
was amazing that once he was able to do that, all kinds of stuff came out. He was going for walks, he was baking cookies, with the grandkids, he was doing all sorts of things. So sometimes I think it's maybe that little bit of a confidence boost too. And so I have to tell you, Todd, people are asking about your men's group. So do you want to put a little pitch in here or talk
Sure.
about your men's group and how they could get involved if they want?
Yeah, the easiest way to do that is to really get in touch with support services, and they will connect you up with our group. We meet every other Tuesday for an hour and a half or so. I think we do it at, God, I can't even remember the time. I'm going to have an Uncle Louie moment because I call this condition Uncle Louie, the unwelcomed uncle who shows up and just ruins every holiday event. You never know what you're going to get, but it's really open, interactive. We don't really, push any one subject. I kind of want to find out how everybody's doing and what's on their minds. And, from a group perspective, we find ways to support each other and help lift each other up in the best way we can as humans.
That's awesome. And you guys don't hesitate to reach out to support services. You can call that 1-800-539-9767 number or email them support@lbda.org. And you don't have to navigate that big list of support groups on your own. You can email or call and they'll help you find something that would work for you, whatever you might be looking for. So thanks, Todd, for sharing that.
And I'll put in a
Yeah,
plug. There's also a women's group that meets once a month, the first Tuesday of the month.
nice. So yeah, call up and you can get in all of these groups, or maybe at least one of them that'll maybe open that door to doing some other things too. So let's shift it a little bit. For care partners and kind of that other end. We had some questions coming in the Q&A that really matched up and aligned with this next question. So a lot of times care partners feel discouraged or frustrated when their loved one, seems withdrawn. And so how do you balance, Janelle, or how did you balance? And Todd will have you answer this one too, being supportive without feeling like we were pushing too hard. Like you said, you kind of picked your battles. How did you kind of find that fine line and know when to maybe push a little bit and maybe when to back off?
Well, it's hard. It's really challenging because I'm just thinking about the motivation is as a care partner, you want to try to fix it and make it right. And you can't always do that. So one thing I try to tell people in my groups is honestly, when you just feel like as a care partner that you're up against the wall and you don't know whether to scream or cry because you're just so frustrated, to think about what it must feel like to be them. It's really, it takes you, take a breath, just before you get reactive, take a pause. And I know in my case, my husband was a psychiatrist. He knew a lot more about this illness than I did. When he was diagnosed, I'd never heard of it. And so he knew exactly what was going to happen to his brain and would explain to me about the electrical currents in the brain and how they're going to stop firing. And so we didn't have a lot of illusion about that it was going to get better. I mean, that wasn't really part of our discussion during living with this. But I do think trying to realize that it's the illness and not them, remind yourself of that. And really important to take care of yourself as a care partner because you don't want this illness to take both of you. You have to be strong. You have to get your sleep. You have to ask for help when you need it. Because if you can't take care of things, then he or she cannot, or will not be able to as the illness progresses. So really try to be realistic again about what's going on, plan ahead, try to stay ahead of the things. You may not have everything that you hear about. I mean, different people have different progressions with the way this illness goes, some for years, some not as long, but anticipate things that you might need to deal with and try to plan ahead. I think that is really the best advice that I can give.
Thank you so much. And I know, Todd, you do a lot of education for care partners, kind of on the experience and what that's like. So what advice do you give to care partners trying to walk that tightrope?
Well, interestingly, most of the care partners that I've been assigned as a Lewy buddy and work to support are women because I think about 80% of the victims of Uncle Louie tend to be us men. And there are certain differences between how men and women, look at things and the challenges. And what I've always said is that men by nature, I think, at least, my generation going back, are fixers. Women hate it because every time they bring a problem from work, home, or a friend, they talk about it and they just want us to listen. But our immediate reaction, even with this condition, is we want to fix it for them. So my suggestion has consistently been, don't ask them to do something, but say, hey, honey, I need help carrying the garbage out. It's a little heavy tonight. If you could help me out with it, that would be great. Or I need help at the store picking some things up. Would you mind doing that with me? So engaging that way, it doesn't feel like I'm being nagged or forced to do something I don't want to do. It's more about me helping a person that I care about with what I can still do and provide in this life. And that seems to have gotten a lot of positive feedback. So
That's really, yeah, you're getting some thumbs up and some hearts over there. I know that I had the privilege of working with one of the nuns when I was at the Mayo Clinic, and I asked her one time because she was always very willing to kind of ask for help. And she let me know that she's like asking others for help. She's like, it's good for both souls. She's like, most people want to help other people. And I think you're
and
right. It's like,
men don't ask
yeah,
for help. We don't.
yeah,
Generically, it's kind of against our nature, because
absolutely.
it feels like we're being weak when we ask for help.
You want to be the helper, not
Exactly.
them. Absolutely. Okay. So next question here, and we'll start with Maggie because it sounds like she's planned out her answer there. Are there particular, environments or types of day or types of support or activities that make it easier to kind of get past your apathy or spark your interest?
Um, well, like I said, if it the okay, so first, for me, first thing in the morning, I plan my doctor's appointments first thing in the morning. So I know that I have to get up and get going to get to my doctor's appointments on time. Again, that goes back to that planning. If my day lags, or if my morning lags, then I start to lag. Um, and then I don't care. That apathy sets in. So if you say you're going to do this in 20 minutes, but there keeps being, we're waiting on this person, we're waiting on this thing happens, we're still waiting, that becomes a lag, and I I apathy sets in. So we don't want to do that. So that's why I schedule first thing in the morning. For me, my motivation is travel and grandkids or family. So if it has something to do with that kind of environment, to doing the things that you want to do, if it then that I get to go. I'm ready to go. But if
Nice.
not, I'm not.
Yeah, yeah. I think that's the thing, and even you guys, when we talk about things that interest people, like say music, for example, or movies, not everyone likes the same music. Not everyone likes the same kind of movies. And so it really is individual. So yeah, thank you for sharing that. And then how about for you, Todd? Is there anything that kind of really gets you jazzed or times a day that you find it's a little easier to overcome apathy?
For me now, it's mornings. And my daughter gets up early to go to work, and I don't get to spend as much time with them as I really want to. So because I've got two adult kids who move back in to help me out quite a bit, and they're just amazing. So I set an alarm clock to get up. And my daughter didn't even know that. She's like, oh, wow, dad's up. And I'm like, no, I'm up because I want to spend time with you. I want to give you a hug before you head out. And then it became, we've got kitty cats as well. And, they want to get fed. So I get the secondary benefit of having these amazing little cats running around me going, Daddy, I love you. Feed me. And, so I get up and I feed them. But yeah, I'm up then at that point, and it's early in the morning for me because my alarm goes off at 5:15 in the morning now to get up. But from that point, now I'm awake. I've got coffee that's brewed, and then I grab my phone and I play my brain games every day. And like Sudoku, I play 3 different versions of Sudoku just to keep everything cognitively as sharp as I can.
Nice, nice. And then how about for you, Janelle? Did you find that there was any, kind of things that magical moments or times a day or things that really helped your husband kind of overcome that hurdle?
I think just the routine and knowing what he really liked. For him, he'd been swimming all his life. And so to be able to make the trip to go to the swimming pool that happened, it's not far away, it would take twice as long as it used to take, of course, just by the time, we got there and swam and got out. But there was so much benefit in it. And so to have that to look forward to, put it on the calendar, remind him and plan around it. Was just really important. And that was one of those consistent things that we just tried to keep that going as long as we possibly could.
Absolutely. Good advice. So you guys, I think what we'll do is bring Dr. Wyman back in and take some questions from the Q&A. And I'm sure we can embed kind of that last question we had on our list about healthcare providers. But I just want to thank you all, and everybody use your reactions to give some love here. That was fantastic. Really, really great insight. Really appreciate it. And you guys, we're going to take Q&A until about 3:30 here, Eastern Standard Time. There's Dr. Wyman again. Welcome back. Thank you all. And I know we were slated, I think, today to only go until 3:15. We wanted to make sure we had plenty of time for the panel, plenty of time for Q&A. So if you need to go, please know it's being recorded. You'll be able to watch that Q&A later and see all the responses. So I wanted to get started here, and Dr. Wyman, I think I'll have you start with this, but anybody else that wants to react to it, please feel free to. I thought this was a great question. So she said, I have the feeling that one characteristic is kind of this on-off switch quality. 1 minute they're on, the next minute they're off, and with the right input, they're off again. So is that a common characteristic that links up with apathy? I think a lot of times that might be more of a cognitive fluctuation, but do we see that in some of the apathy and mood as well?
Yeah, thank you. Thanks to the panel. I want to make sure that was really, really wonderful. Yeah, it does sound a little bit like some of those cognitive fluctuations that we can experience. And so teasing that apart from apathy can be challenging because it's kind of like people aren't really maybe initiating much because they're just kind of having more trouble thinking. And sometimes the severity of the cognitive fluctuations can kind of map onto the severity of anxiety because there's a lot of overlap in some of the chemicals in the brain. So to your point, it is really hard to tease apart, but it does sound a little bit more like those kind of fluctuations that can occur day to day. And so sometimes talking with your medical team about that to understand that a little bit better can be helpful.
Absolutely.
And
then
I'll
anybody
add
want to
that, yeah, for me, and I describe what for everyone to level set with my family is I have a Lewy wall. And I know when I'm having a bad cognitive fluctuation where things are going down, all I want to do is escape. And I have to go to my room. I have to lay down. I may not do anything. I may turn the TV on or not, but I just need alone time. And I know part of it is the apathy, part of it is, how Louis is affecting me, but there seems to be, certain things that trigger it with me. And a lot of it is when I get overwhelmed. So if something's going on, and like someone in the family's having a big problem, as two of them start arguing, I can't deal with it. I'm like, guys, really sorry, I've kind of hit my wall and I have to retreat. And I think Kate's right. I think part of that is the anxiety piece of it as well. It's scary. So I recommend everybody, tell them about the Lewy wall and level sets. Like when I feel like this, I need alone time. Just let me go be by myself. Don't come in and check on me and just give me some time. I'll be okay.
That's really great advice to kind of set those boundaries and expectations.
Mm-hmm.
And then with that, Janelle or Maggie, anything you want to add to that?
I would just add that as a care partner, we can often anticipate when there's going to be a bad day, or there's going to be, I mean, there's a lot of volatility that you can't plan for, but you can plan pretty much that if there's going to be an intense situation, whether too much family or too much input or something that you have no control over, even that came out of the, left field, that the person may rise to the occasion. Your loved one may be fine and they may get through it, but you can plan that they might then just have a reaction. And like what Todd's saying, you can help organize that and just give them a break, give them some grace, to use your earlier phrase, and say, okay, that was intense, and let's just don't plan anything for a little while. Let's all regroup here, and give some time, so they don't have to go explaining it over and over again that they've used up their cognitive reserve to deal with whatever the issue was. So we can anticipate those things at some point as caregivers.
That's great input. And Maggie, anything you want to add to that?
No.
That's okay. You can totally say no.
And then the other thing I would add, Julia, is that for me, and a lot of people in our, support groups will say that you'll wake up in the morning and you just know you're having a bad day. Be honest, let everybody know around you. I'm just having an off day. I think a key to this is communication, and it has to go both ways. So you, as the person, you know what's going on inside you, and you wake up and you feel like crap, and I don't have a cold, I don't have the flu. Just be honest and let everybody know, so they can give you that space and grace and check in you as needed.
And that kind of ties into something we had talked about, or we had in our questions for earlier, which was, what do you wish healthcare providers knew about this? Because I think a lot of times it does possibly impact engaging in healthcare, maybe even being compliant, with recommendations like doing therapy or things like that. So anything that you guys wish healthcare providers knew about apathy and Lewy?
Well, first and foremost, they need to know how to spell Lewy. So that's my first question I ask all healthcare providers. How do you spell Lewy body dementia? When they start out LOUI, we're good, thanks. You have to ask them, what do you understand, I think, about the condition? How in-depth has your, training been on this? Are you a newbie to this? And realistically, if they are, yeah, your mileage may vary, but you really need to find good GPs, good neurologists, and other healthcare providers that understand the nuances and complexities of the condition, and that it becomes a team effort. And what that means is that if I'm going through something, I want you to be involved and be communicative with the rest of the providers. I have a big spreadsheet I share with all of my providers. It has my conditions, my meds, and the telephone numbers, contact information for the rest of the providers. So that way, if something comes up, like with my surgery that I just had, everybody knows about it and everybody's aware, and hopefully, expects nothing to come of it, but if it does, be open.
Absolutely. I love that you're taking that advocacy role, and because we all have to do that in our own healthcare, unfortunately. Janelle or Maggie, anything you want to add to that?
For me, apathy, I want them to know that apathy means that I don't care about doing anything. This does not equal depression. Apathy does not equal depression. I'm not feeling sad. I'm not down. I'm not depressed. And I don't hurt. It's not fatigue. It is not pain. It's apathy means that I just really don't care about the doing part of anything. I don't want to do it.
Yeah. And that's shouldn't be assumed to be other things. That's good advice. Anything you want to add to that, Janelle?
Well, just to take it a little bit of a different direction, I am still so surprised and so disheartened by how little so many providers know about this illness. It's just really unfortunate, because the people who are living with it, whichever their impact is, there's a lot of damage that's done, or a lot of time that's that's, passes before things get figured out. So I just would say, if you're in the care partner role, it's really important to try to, as Todd says, to figure out whether your provider knows anything about it or not. And if they don't, to take the role of trying to educate them or find someone who will. You may not be able to do it in the middle of a meeting with your loved one there in the office. So I encourage you to send something in advance over the portal to their medical provider, talk to the nurse practitioner, find a way to intervene so that important information can be shared, whether it's the medications that can be tolerated or the impact of what's going to happen if somebody gets anesthesia. There's so many, many practical things. And unfortunately, many doctors think they know everything, and unfortunately, they don't about this particular illness. So I just encourage you to be a good advocate, because often no one else will do it for you. And it's not always easy. It can be a little exhausting, but super important to keep the information flowing, and don't be shy about speaking up for your loved one.
Good advice. Very good advice. And this next question I'm going to pose to Dr. Wyman. Is there a link between apathy and someone having a lack of empathy?
For some people, there can be kind of that emotional apathy. We think that it has to do with some of the changes in the neurotransmitters, and even some Lewy pathology that impacts the part of the brain that helps us with emotion regulation, but also recognizing emotion in other people. And so some of that emotional blunting is sometimes what they'll call it, or just some of that lack of reactivity or empathy is a very biologic symptom associated with Lewy.
Have any of you experienced that feeling of lack of empathy?
Yeah.
Go ahead, Todd. And Maggie.
I used to be so, outgoing and caring about the people around me. And I could watch a TV commercial that was somewhat sad, and I'd be sitting in the corner, kind of like, oh my God, I'm crying over a silly commercial. And it just, over a period of time, just diminished bit by bit by bit. And it's not that I'm flat per se, but I don't have the emotional roller coaster that I think is a normal part of being a human being. It just kind of is different. It's hard to describe, but I just don't feel like I get the ups like I used to, the sadness like I used to. It's flatlined a lot.
Yeah, absolutely. And then how about for you, Maggie?
For me, and I agree with the flatline part, it's you just don't feel anything. You go to a funeral and you're the only one dry-eyed, and you feel bad, and you feel horrible. You it's not for lack of feeling, but you just don't feel it. And I personally agree that the empathy part has to do with the apathy. There is a link between the empathy and the apathy. Because of that, you don't care about doing anything, and now you don't feel anything. So
Yeah. And that sounds like that blunting that Kate was talking about and describing. Yeah.
Very much so.
Yeah. Anything you want to add to that, Janelle?
Well, I just was thinking, my husband, as I said earlier, was a psychiatrist, so he was empathic by nature. I mean, he listened to people, and that was what he did. And whatever drew him to that profession, he grew to where he did not really have that anymore. I mean, he lost his engagement. He was retired, of course, but he must have on some level really missed being able to connect with people, in that way. And so I hear what Todd and Maggie are saying just about how it hurts you as well. I mean, you feel what you feel, or don't what you don't, but that there's this grief that's underlying it, which, then might begin to borderline on depression or sadness. But it's this overriding sort of sense that you do know what's going on, and you miss having those deep connections at those times. And so again, from the caregiver standpoint, to really appreciate what it feels like to be them, and they're living with their own limitations, so just to recognize that, I think, is helpful.
And I would
Absolutely.
add, I think this is a condition of gradual losses, and you feel like you're losing things, not necessarily day by day, but when you tell people about the condition, most people tend to withdraw, and not because they're angry about it. They really just don't know how to respond. You've got the D word, you've got dementia. Oh my God, is it cooties? Is it contagious? So if I hang around you, will I get it? Don't hug them because it might transfer. But you're losing that connectivity, that connective tissue that you had with friends and a lot of family. And as things go, like, as apathy progresses, I feel like I'm losing a lot of that emotional connective tissue that I have with just everything around me. And still trying to find things that I, get great pleasure in becomes more of a battle over time. Not going to give up.
Absolutely.
Still trying.
Yeah,
But it it's a loss, and we know it. And I think a lot of people think that because we have dementia, we don't know that we're losing these things. That's not the case. We know,
mm,
like, Janelle's husband, he knew that he was losing that emotional connectivity with people and, potential with patients, even towards, the end of the career. He just didn't feel it as much as he did before. And it hurts, really
absolutely.
does.
And that's,
Absolutely.
people ask the difference between Lewy body and Alzheimer's, for instance. Well, and my mother had Alzheimer's. With Alzheimer's, you don't know. With Lewy body, we know.
Yeah, that's very true. A lot of that insight.
Yep.
So,
Absolutely. Well, I just noticed the time, you guys. I could literally sit here and talk to you all day if you can't tell, and probably would have. So, any last words that anyone wants to give before I give our final remarks? This was amazing. And I just want to thank all of you for being so candid in such a sensitive conversation. I think this was just a treasure trove of insight and awareness, and I can't thank you all enough.
I'll just add, connect with support services. The biggest thing that for me when I was initially diagnosed is a feeling of being isolated. And because I didn't know what the condition was. And when I connected and talked to Brandy initially, who's now my buddy, I was connected with a support group that was run by Pam at the time. And I didn't feel alone anymore. I didn't feel uh, like I was the only one in the world standing in front of this condition. And I'm sure from Janelle, when the caregivers get together, it's the same thing. Because when
Mhm.
you're in the home, you are somewhat alone. But when you connect with people, even if it's via Zoom, I know that I'm not alone in this battle any longer. And God, that feels good. I know they
Absolutely.
can't take it
Wise
away,
words.
but it feels good to not feel like I'm the only person in the world with this condition.
Absolutely. Wise words. Anyone else want to add anything? Okay. All right, you guys. So, on behalf of the Lewy Body Dementia Association, I'd like to thank you all for taking time out of your day to join us. Thank you, Dr. Wyman, Janelle Greenberg, Maggie Isaac, Todd Doty, for sharing your knowledge and your experience with us. As a reminder, everyone, you're going to get an email in about a week with a link for the recording to the presentation, as well as resources that we talked about today and links that were mentioned in today's webinar. We invite you to visit the landing page for our website on our website to stay informed about the upcoming webinars and access past recordings. And Rose will drop that link in the chat now. Our next webinar, we're doing a little shift here, will be Tuesday, September 23rd at 2 p.m. Eastern. We will be welcoming Dr. Federico Rodriguez-Porcel to present a high-level overview of the drug development process, taking a deeper look at the three main phases of clinical trials and the role and rights of research volunteers. Rose is going to drop a link for that registration page now. So finally, last but not least, please take a moment to complete that survey that we'll launch as you leave our Zoom room to inform our content. And we look forward to seeing you all in September. Thank you all so much.